Welcome you all on behalf of the Bombay Ophthalmology Association to this first edition of a new concept called as Eye Crash, where we have the masters telling us how they were caught in tricky and tough situations, how the plane almost crash landed, how they managed to land it safely. And we have a phenomenal lineup of speakers today. And to introduce them and to take things forward, I would like to invite our president, Dr. Himanshu Mehta, to please come online. I would also like to welcome Dr. Keiki Lahane, along with all the faculty. Sir, welcome to the program. And Himanshu, sir, can you please introduce the speakers and take this forward?
Friends, eye crash investigation has been designed and conceptualized for the simple reason that all of us will have complications in life. All of us will have problems, some known, some unknown. When you have a subluxated lens or you have posterior polar cataract, or you know that you can run into complication, you're prepared. But there are times when it's not a good luck for you. All cases are going on well, and suddenly out of the blue, trouble strikes. And you don't know what happened exactly, and it just happens in a fraction of a second. That thin line of demarcation, as I put it, the Lakshman Rekha between the anterior segment and the posterior segment, the posterior capsule, is what decides whether you're a good surgeon or you're an idiotic surgeon, unfortunately. So the moment we cross our Lakshman Rekha, God will give us a tight slap. So here we have a lot of very, very eminent speakers who will be telling us exactly what kind of complications can arise on table, how well can you manage them, what you should be prepared subconsciously, what is it that we can do to avoid these problems. We want to have this kind of a series going on every third week on a Monday evening, so that we learn a lot from our national and our local people and international people, to see that we run into lesser complications, we share knowledge with each other, and if it has happened to all the speakers, it can happen to you also. That is the most important thing. If it has happened to someone, or if you have read in the book, remember it can happen to you. And this is what we need to have. We need to have an understanding how to take care of ourselves, control our nerves, and see that we can get in the best situation. So Dr. Lahane, I would like him to say a few words.
Himanshu has came up with the crash. I think this eye crash is a very good initiative and concept also, because here everybody gets the problem, and once he gets the problem, then what happens, we avoid to show it. So if people are learning, and if you are showing how you have managed, that definitely going to help. So I appreciate what he has decided, and I think the speakers are also very good speakers, and I think the people who are there, they may be senior or junior, they will learn from you. So my best wishes, and thank you, Himanshu.
We'll start with the first speaker, Dr. Harshul Tak. He is known to show some very interesting cases, but right at the onset, I would definitely thank all the speakers to be bold and courageous to show complications, to accept responsibility. I guess the first thing in life is to accept that I was wrong somewhere, and I'm ready to correct myself, is a very major step of life. And thank you all the speakers for being with us so promptly and telling us what exactly can be going wrong. And we welcome you all to the show. Thank you so much. Harshul, over to you for the first show.
Right. Thank you so much, Himanshu sir. At the outset, I'd like to thank entire BOA, Dr. Lahane sir, Dr. Keiki Mehta, Himanshu sir, Dr. Sumeet, and everybody for giving this wonderful opportunity to be a part of this beautiful concept, eye crash investigation. And I feel privileged and honored to be the opening batsman for this web series.
Open it up.
So I'll be showing you two or three cases quickly in 5 to 6 minutes. So these all cases were saved nicely. Only I'll be showing you few which are suitable for eye crash. First, let's start with the mild problems which are there. So this is the case, as you can see here, as I was making capsulorhexis, at this point of time, rhexis tries to go outside. Now here, we need to understand that if we don't stop at this point, and if we don't rectify this situation here, the rhexis, anterior capsulorhexis can go in periphery, and we can have anterior capsule tear there. So we need to stop at this point, put some OVD in front of it and use a microcapsulorhexis forceps and look at the direction of the pull. As taught by Dr. Brian Little, the direction of the pull has to be centripetal. Look at the direction of my forceps, it's going in center. And look at how the rhexis is coming back on the right track. Look at this slow motion again. Try to hold the rhexis from near the base, and your direction of pull has to be towards center. Rhexis forceps has to move towards center. By using this maneuver, believe me, you can get any kind of rhexis which is going outwards, right, in the right track. Let's have a look at another case. This case, the pupil was mid-dilated and chamber was shallow. Patient had narrow angle. As you can see here, the rhexis is slipping down here. As I'm trying to make capsulorhexis, now it's beneath iris margin. So I can't see where the rhexis edge is. So whenever you have a situation like this, so what I did here was not to do anything blindly. I decide to make a side port on the left side. So I go ahead and put some OVD beneath the pupillary margin, make one side port incision here, and put iris hooks. I know that the rhexis is this side, that the edge is, when I retracted the pupillary margin, I saw that the rhexis margin is, the edge is here. So I take iris hooks from below and retract the pupillary margin so that now I can have a proper visualization here, there, and I can get my rhexis on the right track. Again, same maneuver, unfold the flap, and look at the direction of the force coming back in the center, and the rhexis is coming on the right track. So if you use this maneuver, you can get the rhexis which is going outwards on the right track, and you can finish your case. So this was just a difficulty which was not of that level, but what Dr. Himanshu wanted here was a real difficult situation. Look at this case. This case was a plan for toric IOL, had little bit of posterior polar element also. So I make a capsulorhexis. It's a perfect capsulorhexis, as you can see here. Do hydrodissection, hydrodelineation here, and take off the endonucleus, epinucleus. So everything seems perfect. And before doing cortical irrigation aspiration, I am injecting OVD in the anterior chamber. And now have a look what happens suddenly. So this is real eye crash. My visco cannula, it jumps out from the syringe and it hits. Now I can't make out anything here like what all this cannula has caused damage. But I realized that, yes. So again, have a look in slow motion. Cannula goes and hit posterior capsule. I know that posterior capsule has been hit, but I'm not sure about what is the status of the anterior capsule because there is a lot of cortical matter which is there. But if when I look at this, there's a clear posterior capsule rupture which is there, vitreous is there in anterior chamber. So I go ahead. Now at this stage, what we need to do is to now maintain anterior chamber at all the times. Now don't let your anterior chamber fluctuate so that whatever damage has been done, whatever vitreous has been prolapsed, more vitreous doesn't come out. So I go ahead and put some viscoelastic. Now do some anterior bimanual anterior vitrectomy here. And after that, I put some tricot there. So you need to do adequate anterior vitrectomy to clear off the entire vitreous from anterior chamber. And I'm always maintaining closed chamber. Again, putting viscoelastic before withdrawing and in turning off the irrigation. Now here, this is the first, I was on cut IA mode. So I was cutting the vitreous, and this is now IA cut mode, the same probe I'm using to aspirate the cortical matter. So from one side, the cortical matter is taken off, again maintaining anterior chamber. Now changing my hands, going from the left side, taking off the cortical matter. Now, once this cortical matter is clear, I can see that the posterior capsule is ruptured like this here, and anterior capsule is also ruptured. Anterior capsule is also torn. So take off all the cortical matter. Now, the problem was whether I can put a single piece toric IOL in this case. And this patient has 3 diopter cylinder. So what I decide here, because there was a big posterior capsule rupture where edges were not, regular, and anterior capsule was also ruptured. So I decided, and the toric IOL, the implantation axis was around 90 degree. So I decide that it's not good to put toric IOL in this case. And the same power of the 3-piece IOL was not there in the OT. So what I decide to do at that stage is to defer the IOL placement on the next day. So I go ahead and do complete antivitrectomy and close this case. On the next day, as you can see here again, anterior capsule is torn, posterior capsule, there's a big defect there. Go ahead and put some chondroitin OVD, enlarge the incision, and this is a 3-piece IOL which goes in the sulcus, and the 3-piece IOL is put in sulcus. And later, after 1.5 months, I did surface ablation for the patient and removed the cylinder. Other eye also had a toric IOL implanted few months back. The patient was happy at the end. So this is the end of the case. Thank you so much for giving this wonderful opportunity, Dr. Himanshu, sir.
Thank you, Harshul, for sharing such lovely cases. I think brilliant, very well managed, Harshul, absolutely brilliant. Let me go to the first case, the rexis which was going on the other side. You could have also converted from the opposite side and meet the 2 rexis, make the 2 rexis meet. That's one option we could have.
No, but you can see the direction it's going out. It had not gone, beneath the pupillary margin, and I could see. So if you try to come from the other side, there's the option which you have when the rexis has gone towards equator, You can't retrieve that rexis, so then you try to get it from other side. Otherwise, you always try to do quick pull or, centripetal pull. So most of the time, these rexis, they come back on the track. But direction of the pull has to be towards the center.
Joint here and your shoulder joint to move around your fingers and your hand so that you can get a good amount of turning on that. So excellent. And even the other case where you had a posterior and an anterior capsule, don't be afraid to finish off the case and not put the lens in the same sitting. Have the courage to do that on the second time. A very important take-home message, I guess, wherein you handled the anterior capsule tear and a posterior capsule tear. But if you see the eye, the next time you went in was a very quiet eye. So the putting in the lens was like a cakewalk.
Yes, because if you manage it properly, you do good vitrectomy, you follow the principle, I think it's not an issue.
If I can just add on.
Ji.
Also had the pleasure of injecting a tip right into the eye. It's from that day onwards, I only used Lure lock syringes. I never used regular syringes. Because once you have viscoelastic, it is going to slip. It's only a question of when.
This was also Lure lock. This was also Lure lock cannula and syringe. But only thing is that, it happens, I think, once in many years that assistant gives us, which is not that tight, and that was not your day, It
was not your day, and I agree with you. I have had in a Lure lock, not very locked properly. In that hurry they gave you, and you have, all of us have got it, that you have ruptured the posterior capsule. One more way, after a smooth functioning of a cataract while pushing in a lens. We have seen that with the injector. Sometimes the injector has just pushed in the lens with the posterior capsule because it was with a jerk.
Yes.
So I have switched on to the screwing of the injector rather than the push injector.
Yeah, we have all injected.
After that incident, what I also learned is to always point the tip of the visco cannula while I'm injecting, not towards posterior capsule. No, that be careful that it can jump. So always try to keep it parallel to the iris plane, not posterior. So that's another thing which I learned.
Dr. Namrata, any comments from you?
No, I think what Harshul did do was absolutely fine. But then dual lock, I think we say, but we normally don't use those kind of mechanisms. And when it happens, then only you realize that, actually this has happened. And retrospectively, you think that you have to change it the other way and do it. But of course, it does help if somebody shows like that in future one has to take a precaution.
Great bouquet of cases that you've collected. I mean, brilliant. Gaurav, would you like to say a few words?
Hi. First of all, thanks, Dr. Himanshu and Team MOS for doing this wonderful program and for inviting me as well. And Harshul, I know that you have designed your own viscoelastic cannula, which I also use, and it's quite amazing because it's a slightly finer gauge. I think it's a 21. Is it 21 or
no? 22? It's 25 gauge. Yeah.
25 gauge, right? Gauge, so what happens is that I was just thinking that what cannula usually comes with the viscoelastic is usually a much wider gauge, which is almost close to, I think, 22 or something, and yours is a little finer. So I use it because it's very easy to go inside. You don't have to push in through a fine port, so it makes it easier to go into the bag or something. If you are in an urgent situation, you don't want to push in viscoelastic from your port. But on the other hand, when you have a very fine cannula for a conventional viscoelastic like HPMC, your force required will be much more. So I realize that, when I use your cannula, sometimes I have to push it very hard, and that can translate into a situation where it can suddenly, go. So maybe, we have to match the cannula to the viscoelastic as well. For example, with this coat and maybe with sodium hyaluronate or whatever you're using, I think we have to be careful about that. And of course, the lure lock thing, which everybody is emphasized. Both things are very, very important.
Yes. So I've been using this cannula for now almost 2 years, more than 2 years. So yes, you're right that it requires little more pressure than the usual cannulas which comes. But once you get used to the amount of pressure which is needed, it's comfortable, But the only thing is, yes, lure lock has to be tight. There is no doubt. Yeah, that was the only reason it jumped. Yeah.
Harshul, a quick question from the audience that you had done a wonderful vitrectomy. Why did you not use a 3-piece lens on the same day?
Because it was not there. Same power was not available with me. Otherwise, I had put at the same sitting. Yeah, in the same sitting. So
that was the answer. So you had handled the case very well. And you could have done it, but you chose to do it the next time. Thank you, Harshul. We are going to come back to you for this, and thanks for your time and efforts. Harshul is a prolific surgeon in Jaipur. He's a great speaker at multiple places. He's devised so many things. You recently saw something coming up on our forward. Harshul, just describe that. I want you to talk about the new thing which has been designated on your name.
Sealing of clear contact incisions. Yeah. So this is a technique recently published in JCRS, JCRO, to be precise, and it's very simple but very effective technique that whenever we try to seal our side ports and main ports, we observed that almost 40% of side ports they leak. So if we do serial test of all our wounds, incisions, we realize that only 5 to 8% of main ports leak, whereas 30 to 40% side ports leak because there is a lot of stretching which happens on side ports. So what I decided to do is to do hydro stitch of all the incisions, and after that also check they are leaking. So I just nick the limbal vessels because we have a lot of vessels there at the limbus. So just nick them. It's all under topical anesthesia only with 26 gauge needle, and with the using that same needle bevel with the surface tension, I keep it there blood for just 1 minute, 1.5 minutes. And we all know we have been using the blood for auto grafting also of the pterygium excision. When we use the blood as a sealant. So this blood, by two mechanisms. Firstly, it clogs the micro leaks which are there from the incision, and secondly, it forms a physical barrier there. So it just forms a small clot there, and we do Seidel test again. So 100% of the leaking incisions, they seal. There is no leakage at the end.
Thank you, Harshal. That's a nice novel thing. If the wound sometimes, whatever you do, it doesn't close, you could always use the autologous serum and it'll seal itself very well. Thanks so much. Now we have a very, very interesting person, Dr. Namrata Sharma. She needs no introduction, from the All India Institute, and she has huge experience and some lovely videos that we've seen over a period of time in the last few years. And ever so present during COVID time, we've seen her face every day with all the presentations from AIOS. Ma'am, thank you so much for taking your precious time and being with us and sharing your knowledge on the Bombay Ophthalmic Association. Over to you for getting us some more knowledge on Descemet membrane detachment.
Thank you so much, Professor Himanshu Mehta, for this honor to be here. And I think I would like to congratulate the entire POA team for this eye crash investigation. And the number of participants who are showing here speaks volumes. Popularity of the program and of the concept. I think it's a great concept. I would like to congratulate everybody, Dr. Himanshu Mehta, Dr. Keiki Mehta, Ragini, Sumeet, Nikhil, Manish, for this initiative. I'm going to be talking to you about Descemet's membrane detachment, which can happen intraoperatively. So some of the videos are going to be intraoperative, and which can come to you post-operatively also. So this is basically a based assembly of everything, and how to deal with it also. I'm sure you all know it, but it is just to reinforce on what can happen and what one should do. Now, this is, you can see a Descemet's membrane detachment, which is present right here, and you can actually see it. So once you seal the wounds, then important thing is at the end of the surgery that you put an air bubble and see to it that it attaches the correct way. It doesn't invert, because then it's not going to, attach the correct way. It should be just the correct way so that the flap sits just behind the stroma. Now, this is yet another case of Descemet's membrane detachment, which is present at the wound site, of course, which can be seen here on the intraop OCT microscope, but always try to see it on the main wound. And sometimes you can see actually that this is this small piece of Descemet's membrane is detaching. And once you, again, in these cases, at the end of the surgery, do put an air bubble. And because it's shallow, it will take care of itself and it will attach by itself. Now, this is yet another one, which you can see right in the center over here. And again, the air bubble is instilled there. And there are several causes to it. It can cause double anterior chamber also in the post-operative period. So one has to avoid that. And if you do encounter it in the post-operative period, it is important to address it. Again, go from the area which is relatively clear, which is non-edematous, because this is a localized Descemet's membrane detachment. Get a single bolus, keep that pressure for some time over there, because once you keep that pressure for some time, it will get attached. And as you keep that pressure, you'll also see it will clear up right on the table before your eyes, if you keep it for good 4 to 5 minutes. And then when you take out the needle, just put a blob of viscoelastic or keep the pressure on, because you don't want the air bubble to come out. Most of the cases will resolve with the air bubble. You wouldn't need to put SF6 or C3F8 gas. Now, this is yet another case. This looks attached. It is not on the IOCT. It is not intraoperatively also, because this part has not begun to become clear. But as you will give external massage notice like this, it will start to clear up. Of course, it shows on the IOCT, but even if you don't have the IOCT, it doesn't matter, because on the table itself, it will start to clear up, and then you know that it is pretty much attached. And then again, the trick is the same. That is when you put a little bit of pressure there so that with your needle, your thing doesn't come out. Now, this is yet another one, which is not exactly linear, but it is kind of curvy linear. And again, this external massage is something which really helps, because it helps to cause the movement of the fluid out of that space. And on the table itself, the clarity will show you that the Descemet's membrane is pretty much attached. And then as you come out again, notice that it should not clear up. Now this is yet another case where the Descemet's membrane detachment is present, and again the air bubble is being instilled. This was in fact a case of DISSECT triple, so an air bubble is being instilled, and on the table itself it will clear up. So I think that is very important now. This is another sign to show that it has become attached when it clears up on the table itself. And this is just to show the follow-up on after 3 days. And then at the last follow-up. This case required 2 bubbles. So sometimes you may require more than 1 bubble for it to clear up because it may not get attached completely. Now, at times what may happen is, this is a very complicated case. So the Descemet's membrane detachment is there, but it is taut. Now, if it is taut, any amount of external massage or any amount of putting the air bubble will not cause it to oppose. Now, this is the 3rd time that we are doing it. Twice we've rebubbled, but it is not attached. So when you look at the pre-op OCT and you know that that taut DMD is there, then you have to put a suture here like this, which can be removed on day 3 or day 4, but at least for 3 days, if it is attached, then it will remain attached. So you may have to use combined suture and combined suture as well as a tamponade with the air or the gas. Of course, this is a difficult case, and this is after a keratoplasty. There is a Descemet's membrane detachment when we try to do phacoemulsification. In this case, again, the air bubble is instilled, but notice that it is not that clear and it is still detached. So you have to drain out the fluid a little bit, and when you drain out fluid a little bit and then you instill air bubble, then it will become attached. It will also start to clear up. So even if you don't have this intraop OCT microscope, you do come to know that it is attached by the clearing that you see on the intraop. Now this is just a case to show that as phaco was being done, the Descemet's got detached because the Descemet's membrane was loose. And how do we come to know? Because it is going right from here up to the wound, and there is iris prolapse also, and this Descemet's membrane is completely detached. So at the end of the surgery, you have to ensure that it is attached. So after doing irrigation, aspiration, you have to ensure that the air or the gas bubble, whatever you want to put, is there. Now, in such case, it is important that you put a gas bubble because it is right from limbus to limbus, almost kind of a detachment. And I think that is the most important thing, is to recognize it, that it is there. And this was also a case of Fuchs dystrophy. So that is why this problem was there. And like I said, that the role of external massage cannot be underrated. That is something you should do routinely only. Even if you put a air bubble, always do a little bit of massage, because that helps the on the table itself for the cornea to clear, and then you know that whether you have an intraop OCT microscope or not, it is attached. So I think the key message is that you have to put the air bubble, you have to do external massage, and you have to see that it is cleared right on the table in front of your eyes, and then only you leave the case. So thank you very much for your attention.
Thank you, ma'am. I think wonderful presentation to see all the cases, intraoperative to even in a keratoplasty, get all these detachment. But for the unfortunate us who do not have an intraoperative OCT, what is it that you would like to tell us? If you don't have an OCT, you suspect, please go ahead, tell us, how do we manage on table?
So on table, I think the most important thing is the moment you realize that there is a Descemet's membrane detachment, which is there intraoperatively, you have to put the air bubble. I mean, it is the best to do it before closing the case. And it should be put in such a manner that the everted flap of the Descemet's membrane is in the right direction. It cannot flip back in the wrong direction and then you put the air bubble, because then that area is going to remain bare. And in the post-operative period, although it will not make a difference, but in that bare area, you may have bullae, which may be present, which are generally present if the area is devoid of Descemet's membrane. Sometimes the endothelium will migrate and will cover it up. So it should attach in the correct direction. I think that is the most important thing. And doesn't matter if the pressure is a little bit high. It doesn't matter for some time. You can always give Dimox to the patient, or you can give 2 Dimoxstat, but the pressure remaining high means it will get attached. But if there is hypotony of the pressure becomes low, then it will again flip-flop. So I think that is most important thing. And then second thing that you should always do is do a little bit of external massage. For small detachments, probably you may not require a massage, but for large detachments, you would require a massage. And keep that pressure with the air bubble on or with the gas on for at least good 4 to 5 minutes. So on the table itself, you will see that the area from where the detachment has occurred will clear up right in front of your eyes. So even if you don't have an IOCT, the clearing itself on the surface of the cornea will tell you that it is pretty much attached.
The air bubble should be injected from the opposite side of the roll-up.
Opposite side of the roller, so that it kind of unfurls like that.
Yeah.
If you do it from the side where it is already everted, then it will further increase the area of detachment.
And the massaging action should be from the attached to the non-attached area.
The massaging action should be from the attached to the non-attached.
Do you have to remove epithelium? Do we get anything by removing the epithelium? You don't have to remove the epithelium.
You don't have to remove the epithelium. Nevertheless, if in your external massage a little bit of epithelium does get removed, it doesn't matter.
And if you don't have gas, don't lose hope. It's fine to push in air.
It is it is good to push. One thing I've seen that if you have an intra-op Descemet's membrane detachment and you put air bubble, almost 100% it will become okay. But if it is chronic or if it is long-standing, then you may have to think that you may require a gas. Or if it is not planar, it is curled up or scrolled up edge, then and it is long-standing, then you require a gas. Otherwise, air bubble is good enough if it is on the table.
So what is chronic according to you? Is it 3 days, 5 days?
So chronic according to me, and we did do a study where we wanted to know because there were many cases which were referred to us. So we took 100 exact consecutive cases which were referred to us for Descemet's membrane detachment, and this is published. In fact, for corneal edema, and these cases of corneal edema, 100 cases we subjected to anterior segment OCT. In 67% of the cases, there was Descemet's membrane detachment. The next thing we wanted to know was for how long can this remain so that you can attach it. So we took cases which were within 8 weeks. So which means that even if a Descemet's membrane detachment is there for 2 months, you can still address it just by putting an air bubble or by putting a gas without having a patient to refer for an endothelial keratoplasty. So don't lose hope. Even if for 8 months there's a Descemet's membrane detachment which comes to you, you can still address it without actually doing an endothelial keratoplasty. I would extend it a little further because now we are taking cohort which is within 12 weeks, because 8 weeks we know will work, but we don't know beyond 8 it will work or not because we didn't recruit more than 8 weeks. So now we are doing a study on cohort within 12 weeks, whether we can still attach it or not.
Okay, and gas to be done if it's a chronic case, then only that gas. And which gas would you prefer, SF6, C3F8?
I almost always do C3F8, but people do SF6. But I believe either it'll go away with air if it is not that chronic. But if it is chronic, it is best to put C3F8.
And do you dilute it 15% like a retina guy?
Dilute it 14% C3 because it'll expand. But I don't burp it. I'm not overzealous about burping it because, like I said, I would rather have a little pressure on the higher side, at least in the first 1, 2, 3 days, because once it is stuck there, then I know it is not going to come back. But once there's hypotony and it's, kind of gone down, then again, you'll have to go and redo it. So it is better to give, Dimox or give Dimox is all that you would probably require with anti-glaucoma medications, maybe like a glucomol or timolol. That is what you would require. But the best part, so many cases you are able to defer a graft, endothelial keratoplasty. And that's a big gain for the patient as well as for the surgeon.
When would you drain it? how do you take care of draining at times?
So if it has to be drained, I would drain. If you look at the anterior segment OCT, if it's really taut, there are times, of course, I didn't show it, when you actually have to make a stab incision because it's so taut, the Descemet's membrane, that any amount of air that you put, it's not going to, it's not going to come up like that. It's absolutely straight and taut. So at times from one side, so that you a break in the Descemet's membrane and then simultaneously inject gas from the other side. Then taut Descemet's membrane kind of breaks and then attaches. So that is there. Draining I would do only for cases which are post-keratoplastic. So they are complex cases. I can't remember of draining in any case where it was done after phacoemulsification, but after post-keratoplasty, you may have to drain it. Like I showed you the case that we did.
One more thing, while injecting the gas, you just pushed in a Q-tip very well so that the gas does not escape out. Even though you used a 30 number needle, the gas can still escape out.
Can escape out. So you can put a blob of viscoelastic where your needle is going through, something like a helon. Even that, if you take out, the helon kind of seals it. Else, you can put a little bit of pressure with the swab stick and ask the assistant to put the pressure on as you take out the needle yourself. And then ask the assistant to release the pressure very slowly because you've taken out the needle and it's possible that your bubble may come out even, after that. So then the assistant takes off the pressure very slowly so that the whole thing kind of remains.
Dr. Lahane sir, any questions? Anything that you would like to share?
Yes. Basically, what Namrata showed is very, I think, excellent. And 2 months is, I think, very good lines he told us. Otherwise, we were thinking for 1 week or like that. Secondly, OCT. Those who are not having the OCT on the microscope. In such cases, what directly we are making the tunnel. So that will leak. Instead of that, what we do, we take a 29 or 30 number needle, go parallelly to the limbus where it is Descemet is attached, and then after making 4 millimeter tunnel indirectly, then go inside and then inject the air or gas, whatever. So that what will happen? This is an indirect tunnel, and the air bubble or the gas will not leak. Otherwise, the straight opening can leak. But here, the Namrata can say with OCT. But those who are not having OCT, they can use this type of indirect tunnel. That definitely helps.
Most important thing, ma'am, how to avoid it. I think that is the most important thing. It is our keratome which is responsible. Am I right? And the phacoprobe, if you don't have a proper incision.
So I think important thing is that you should have the correct instruments. When you use your MVR blades or sideport blades again and again, then this can happen. Second thing is you have to recognize preoperatively. Fuchs dystrophy is one. Second is your PPMD. Third is your, there are genetic, cases where your Descemet's membrane is going to be loose. So if you have those kind of cases, then avoid a temporal incision, because if you think your Descemet's membrane is loose and you might require air injection, then it is best, because phaco entry is going to be superiorly, and if you put air bubble, then air bubble tends to go superiorly. So avoid temporal incisions, then go for superior incisions in those cases. Counsel the patients beforehand that you have a loose Descemet's membrane and it is possible that you may have a Descemet's membrane detachment. So I think that is very important. And if then you have to change your incisions and not use the instruments again and again. Use fresh instruments for making your incisions.
How would you diagnose it pre-op?
So preoperatively by slit lamp microscopy, you can diagnose a Fuchs dystrophy or you can diagnose PPMD. Telltale signs may be there in the fellow eye also. But these are the only ways. And get a specular microscopy done, especially if you see pigment deposits on the Descemet's membrane, or you see metal beaten appearance on the endothelium or the Descemet's membrane, which you can see by the sclerotic scatter, or you see guttae which are present more centrally or peripherally. So you would know that this is a Descemet's membrane or endothelium which is not healthy, and it is likely to be loose and it will come out.
One more question before you leave, ma'am. How many times can we inject before we give up? Because you are very positive. You said even if it comes after 6 weeks, you still have very great chance.
We are doing after 12 because I want to know the limit, limit, like you are saying, in terms of number of injections, the limit of duration. And we were very surprised that even at 8 weeks, we could defer a corneal transplantation procedure if we did it. I think maximum injections that we have done are up to 5 that we have done up till now. I showed you a case where we had to do it 3 times, but still, it's kind of with every step you get better. You inject once air, it will attach. Still, some shallow detachment may be there. Doesn't matter. Go ahead and again inject air bubble. Again, some shallow will be there. Go ahead and do it again, but then you need to follow up. And then finally it will be attached. So it is like that. So sometimes you require multiple injections, and with each injection, the detachment, which you can see on anterior segment OCT, you don't have to have intra-op OCT with that, will get better and better, in the sense will become more and more shallow.
Dr. Keiki Mehta, sir, any?
I was very much wanting to ask Namrata, how do you explain Descemet detachments which tend to occur 2 or 3 days after doing surgery? First post-op, the eye is crystal clear. The second day when he comes, you can see the body effect. You have a look and your OCT shows you that your Descemet has come off. I mean, what is the reason why this tends to occur? Is there any specific reason?
So on first day, what happens is you do have a little bit of, say, viscoelastic. It's kind of holding the Descemet's membrane back, which submicroscopically is present, which we have possibly not seen. So that's kind of holding it back. Also, if you see always, I mean, almost always, and this happens with our DISSECT grafts and DMEC grafts, day 1, they'll look absolutely clear, crystal clear. Day 2, there'll be, slight haze. Day 3, there'll be slightly edematous. Day 4, 5, again, they'll start to clear up. So I do feel that this endothelial pump, which is there on day 1, it's being supported by other ancillaries like your viscoelastics or probably your air that you've left, but that kind of starts to function suboptimally after the effect of the viscoelastics. So your BSS plus kind of goes away. So day 2, 3, they tend to drop down, and again. So it is during that interval that some of the Descemet's membrane detachments are picked up. Again, we did a study where intraoperatively on the microscope at the wound, we saw that there were Descemet membrane detachments. We noted it. We put the air bubble. Then we wanted to see, because almost all of us would have wound side DMDs, sometimes visible, sometimes not visible. But we wanted to see when do we not see them on anterior segment OCT. So day 1, again, we did this in almost 70 eyes. Day 1, we did anterior segment OCT. Day 7, we did anterior segment OCT. And we found that by day 7, all wound side DMDs were closed. I mean, there was nothing. But day 1, 30% of the DMDs were still there. We could make out that because on intra-op OCT, we made a note of it. So by day 7, everything, looks almost normal. But this is the reason why they may be there on day 2 or day 3.
One last question. When we instill air, very often the Descemet settles into place. But when you see that patient a month later, you still see fine Descemet folds, and the vision stays at 6'9", a little 6'12", 6'9", etc. Is it because we did not attach it properly, or what is the reason? Because a total haze cornea, which is 660, went down and improved. But at the end of a month or month and a half, you still have not been able to achieve 6/6. And you see fine folds in the cornea.
So I think the endothelial pump takes time to recover, and so you may still see some folds. But if you see them on month 3 or month 6, they would be, they would be okay. They wouldn't have that edema. So this we know by the way we see the endothelial grafts also, that they take time to recover. So I think it is basically that they attach anatomically, but the functionality takes time to come back to its normal, and that takes a little time. But eventually, you would see that by 6 weeks or by 3 months, they would be okay. They would be okay. Of course, I do believe that when the desmoid has got detached and it is attaching, it will never be at the same submicroscopic level as virgin desmoid membrane would be. So even that alignment kind of a thing, would compromise your, visual acuity a little bit. Although the patient may not be aware of it, we can make out by, say, contrast sensitivity, or we can make out by other quality parameters. But I think that submicroscopically, it will never be the same, the same kind of endothelial cell will not be attaching to the same desmosome there, which is there. It's alignment, but it's not the same jigsaw puzzle, which is, fitting into the overlying stroma.
Ma'am, how much time between two injections of air?
I think that suppose I have done an injection today once, and I see that tomorrow there's a shallow detachment, I would go ahead, run and do it again. No point keeping a detached desmoids detached for a prolonged period of time, because you are, giving it time not to recover, and the fluid is there between the desmoid membrane and the overlying stroma, so you don't want that. Whether it is for grafts or for post-phaco desmoid membrane detachment, people say that shallow desmoid membrane detachment would take care of itself, but I would run and do it immediately, the same day, the same time, whenever I see it.
Any specific post-op regime that you would follow after gas injection, air injection?
So Repatec eye drops we've started now because that helps in endothelial pumping. I don't know how much it will help. I don't have data to substantiate that. And of course, sodium chloride, 5% hypersol eye drops. I would give steroids also. 2 hourly if I've been giving them QID, because inflammation has to come down, and I do believe that steroids do help in clearing of the cornea. So I would just pump up the steroids.
Prednisolone? Prednisolone?
Yeah, Predfort, something like a Predfort, not a low dose, because I feel that once you're giving, it should be a full-on, a full-hearted, a full-on kind of a thing. No point giving half-hearted or suboptimal dose. No point giving a Predfort QID. If the pressures are okay, it should be Predfort 2 hourly.
And anything locally like a Xalatan or any latanoprost to reduce the pressure?
So if it has to be, then I would rather give a latanoprost. I generally avoid, because that tends to cause a little bit of reaction also. So I would go in for something like a timolol or glucomol. But having said this, I wouldn't mind if the pressures are a little on the higher side, because I know that a higher side will help to, attach the desmoids. It's okay if it is a little on the higher side, not very high, but on the higher side, but definitely not a hypotony.
Thank you. Thank you so much, ma'am, for such a detailed understanding about desmoid membrane. It's always been in a limbo in my mind as to how to handle it. It's a scary moment when you see it post-operative, and or when you're doing your phaco or you're inserting something and the desmoid membrane just rolls up. It's a very scary feeling at that time. But what you said is a lot of hope. Don't give up. Desmoid membrane is a good friend. Even for 6-8 weeks plus, it can always go and attach. Go ahead and inject multiple number of time, air, gas, whatever that you have to. Don't give up hope. It's a friendly thing. It wants to go and get attached. Leave it to that. Just help it to get attached. I guess that's a wonderful take-home message.
I want to thank you for, getting out all the points which probably we never say in the talks. All the studies that we did helped to do this, and you could only take it out. Otherwise, it's very difficult for anybody else to, take out that kind of a practical experience. Having said this, I would just like to add, even if your desmoid membrane doesn't attach the way it should, it becomes the opposite, and your air bubble is there, it doesn't matter, because eventually the endothelial cells do migrate, that we know from our endothelial keratoplasty. So even if it is the other way around, in the sense there's a small flap which has gone, like this, you put a air bubble, doesn't matter. The endothelial cells will still migrate. It is not, it's quite forgiving that way. And it will still migrate and that air bubble behind.
One last question, ma'am. Despite detachment, the cornea never looks as shiny as it was in a routine case. There's always a little haze that you feel. Is that true?
It's quite true.
Okay.
Like I said, submicroscopically, it will never match what it was in a virgin cornea. There will always be, some fill in the blanks which will be there. But then that's it. At least you don't have to do endothelial keratoplasty, and that's a big thing. That's a small price to pay when you don't have to do a graft.
Thank you so much for giving us so much of enlightenment on a Monday evening. Or Desperate membrane, total coverage, all kinds of detachment with fluid, without fluid, with OCT, without OCT, gas, air, how much, how long. Fantastic. Don't give up hope. It's there to help you, and just be careful with your equipments. Don't first get it. That was the most important message. Use the right instruments, because they are the ones who are creating that trouble for you. Thank you for your time, ma'am, on a Monday evening. We have our next speaker, Gaurav, ever smiling, always ready to help. Gaurav is an absolute prolific surgeon and a great dynamic leader. He's been there with IRSI, he's been chowed all across all India. He's always willing to give and share his knowledge. That is something very important. He would never, if you call him up middle of night also, he's always ready to share information, knowledge with a smiling face. And it's been a pleasure interacting with him in the last so many years. Great surgeon, always a great teacher, and some of the great courses which he holds are really nice. His talks have meaning, a lot of depth. I invite Gaurav. Gaurav, over to you for your next show.
Thanks a lot, Dr. Himanshu. And that was a masterclass in handling DMDs. I really enjoyed it. And thank you for putting together this program. And as you said that, eye crash investigation, something where you kind of have a problem or you make a fool of yourself and then, try to get the best out of it. So I'll show you a couple of cases where I did end up making a fool of myself. But before, as we were talking, I just thought I'll just share one screen for a few seconds and then I'll go on to my presentation. Let's see if this works. One moment. This is actually an unedited video. Can you see it?
Yes.
Okay. So, this happened only a few days back and this is a funny situation. So just watch if it is going to play. So this is a case which I did a femto-assisted cataract surgery. I've already removed the capsular flap from there and I go in and I'm deciding to go for a direct job. And as I start, it's an unedited video. So I embed and as I embed, and I think that, why is it coming back? It's, it's kind of stuck there. Something is not right. I go embed further, probably. And now I'm going to get ready for my job and see what happens. This is like a Mohan Rajan moment. And it's happened to me for the first time in 25 years of my phaco practice. Wow. But this was like, and now, it was a situation, luckily there was a full nucleus sitting there. And I had no idea that this can ever happen to me, but it did happen. So why I'm showing this is that 1 in a million times, maybe this can happen to somebody. And then you have to be prepared to deal with it. And I did go in, I thought I might have to enlarge the incision or something. It's a hard brown cataract. I didn't want to compromise on my phaco as well. And it was embedded there. And I'm only wondering if it had happened towards the end of surgery, what would have happened if it went onto the PC or something with almost no nucleus lying there. And I'm depressing the posterior lip with my chopper and managed to bring it out. And I went on. And anyway, so I'll just go on to my presentation now. This kind of reminded me that this is something which...
Gaurav, this is to prove how hard the cataract was.
I don't know, but it's
making a stone. The aches.
I used to think that Mohan Rajan manufactures those videos. Now I will never think Mohan Rajan manufactures anything. It can happen, like eye crash can happen to anybody, right? So
if it has happened to you, it will happen to somebody sometime for sure.
Yes, and when I then reported this to the company which does this machine, and then I did find out that maybe 1 or 2 other people have recently had a similar experience. So let's all be careful. So I'll
ask you a question, which is Was it a new tip or a relatively old? I mean, if for it
No,
to
this was relatively new. I think this has been autoclaved. It's been so we change the tip after every case. So this tip would have been autoclaved. Maybe it's been about a month or two old. So I did check that how old it is. It's about 2 months old. So it would have been autoclaved like maybe 20, 30 times or more. I'm not sure. So I'll now go on to this presentation and okay, so this again is a case where, as I said, I might end up making a little bit of a fool of myself, but then I thought it's worth taking home a message. So again, a femto-assisted surgery, the problem is not with the femto part of the surgery. So it's again a hard brown cataract with a significant phacodonesis. So this patient had a little bit of zonular laxity and went ahead with the surgery, and looks beautiful after the cracks have been done, almost like a flower petal. So somehow the colors are not coming out right. I'm not sure why, but anyway, that won't matter with the surgery, I think. So freeing up the nucleus a little bit after a good hydro. Cracking, it's a hard cataract. And so this bit went off pretty well, and everything was looking good. And then I went on to, you can see the capsule bulging up like that. Can you see that? And it's a very lax zonules, and the bag is kind of almost touching the cornea there. So I go in, try to remove the cortex, and everything seems to be going well. And here goes. If I'll just take it back for a moment, just watch what happens as I remove some of the cortex from there, then from here, and I'm beginning to feel it. And there I pull the back. So essentially, I was being, maybe this is also a little fast forwarded, and please ignore this small mucus strand here because it was irritating me. It was there for a long time. I kept trying to wash it away, but this is on top of the cornea, this thing that you're seeing. So I wash it away and it'll just come back because it's stuck somewhere on the limbus. So anyway, now what I'll probably stop here and ask, because the whole purpose of this thing is to find an answer of maybe, Keiki sir or somebody else, whoever wants to answer this, that what should we do next here?
Dr. Keiki Mehta sir, Gaurav is saying, what would you do next when he's got hold of the anterior capsule and the zonules are weak?
I think at present it seems to be nice and stable. Let us see how it proceeds.
I know. Dr. Himanshu, anything from you? Like, what would you do at this point?
Yeah. If I
it looks good right now. I mean, it's not bad. You cannot see the dehiscence area at all. It's just that I've caught it and it's gone back, and just the PC bulged forward.
Yeah. First of all, fluidics would be low. If my first sight when I pulled it, I would know how much have I pulled it. And if there is a big zonular laxity, there is no harm putting in the CTR very early. Because the question always is how soon is soon and how late is late with a CTR. So you would be totally.
What would be the first thing you would do right now? Like right now.
First of all, fill in the bag. Never come out without, fill in the bag and keep the chamber stable.
I've already come out now, so that's
the.
So that's the best answer. In fact, I shouldn't have come out right now, and I should have had the infusion on. But my first reflex, as often happens, is to come out, and one should learn. That I think that's a great answer. But now that obviously I'm out, I'll probably have to go in again, either with infusion or with viscoelastic. So let's see what happens. So my first reflex was to come out. Next reflex is, as you can probably see now. Let me see. Is it playing? Okay, one moment. Okay. So now you can see what's happening. It's beginning to move away, and I decide to put viscoelastic. Am I doing the right thing by putting in viscoelastic?
You have little choice actually right now, because the vitreous is coming in, the bag is moving out.
No vitreous yet? but
the bag is moving. Yeah, I mean,
there's no vitreous, but the bag was suddenly the AC is shallowing and the bag is tending to move away. So I need to immediately fill up the
you can take a thinner cannula and go to the opposite sector, sir, and create a visco wave so that it just lies flat.
So that's a great answer, and that's what I didn't do. But see what happens when I put visco from this point, which was probably the wrong thing to do. Just see what happened to the bag. It went further away. So what Anurag was saying was absolutely correct. I should have come from the other side, had a finer cannula, and put in viscoelastic into the bag. But as we were talking about Harshul's cannula, and I didn't have it readily available at this time because I needed visco immediately. I usually keep those cannulas for those situations when I need it. But here, see, I'm now trying to retrieve the situation by injecting viscoelastic from the other direction to distend first the chamber. Then I'll probably use a finer cannula because now I've stabilized the situation with the viscoelastic there. And I'm now checking for what's going on. And then I'm using the final, this is the Harshul Tak cannula, which I was talking about. By this time, my assistant could get it. So I've distended the bag. And with that, now I'm going to try and decide what to do. So now I decide to put in a CTR. And let's see what happens with the CTR. Am I doing the right thing by putting a CTR right now?
CTR is a good idea.
Could I have done something else?
Probably should have
you should have had the pupillary hooks and or the retractor, the capsule retractors to hold on.
Capsular hooks?
Yes, capsular hooks so that they help you to support you from outside.
Any other thoughts? Anurag, anything you would have done differently? Like, would you have put in a CTR right now or later?
No, I would have definitely put in a CTR, sir, because there's very minimal cortex now left to clear. But probably with a different technique. I would have used a CTR injector to put in a CTR and would have started bang on from the opposite direction because that's where the eyelets should remain and the bend of the CTR should remain where the dialysis has happened. The capsular hooks can help to suspend it vertically just to give an additional vertical support, but that at this moment perhaps would not be that essential because we are already through with the nucleus management. So the cortex is all that is left. However, what is playing in my mind is the amount of dialysis that has happened. Probably we would have to fix it with a segment actually. The CTR would not work to keep it in place for years to come. So the segment fixation has to be done, and if it has to be done, it should be done before the CTR is placed so that we can see the equator and exactly where the CTS is going. So that I would put first and then the CTR.
So would you put in a CTS right now before you put the CTR?
No, that's what I'm saying. So the capsular hooks come into play to retract them peripherally. Maybe finish off whatever job is left, and then put in a CTS, hold it in place, and then after the IOL is put in, then fixate the back, tighten it. I'll not tighten it. I'll just put it in, keep it in place.
So I agree to an extent that if I had to do that, if I had to put in a CTS superiorly where the dehiscence was, I would have put in 2 capsular hooks and put in a CTS and then maybe not even put the CTR. It wouldn't be absolutely necessary because CTS would give a support of almost those 3 cars as well. But here, anyway, I think Anurag was with me in the session at the IRSI where I showed this video. I kind of remember him watching this video there. Were you? So he knows a lot about what's going to happen next. Anyway,
anybody in the audience is welcome. If they have any suggestion, quickly text on the chat message and we'll get you online.
Right. So what happened is that so with the benefit of the rest of the video, Anurag already knows what's going to happen next, but let me show the rest who haven't seen this video last month. So what happens is that I try to put in the CTR and you can see that the CTR is beginning to actually cause, because I'm putting it from the wrong direction. And that's why when he said that use an injector, that makes sense. The injector would have really been a good situation here. The thing is that injectors also can be, sometimes there are disposable injectors available now, but I've burnt my fingers with the disposable injector once when it would just not release and it opened up. So, sometimes the disposable injector, which is available in the Indian market, the CTR sometimes is so straight that it does not kind of, open up. It does not kind of perform around very easily. And the good injectors, the reusable ones, which are the titanium ones, which you can get from some of the US manufacturers, they are really amazing. But then you have to have them ready, and they're quite expensive to keep as well. I have one, but I've stopped using it anyway. So here I'm trying to kind of put in the CTR first from one side, then from the other side, hoping that I'll be able. I use the side port, I use the main port. Now you can watch what's happening here, and it's making it worse. The bag is kind of not ready to. I'm hoping that it'll go, but it won't go. So I'm now going to withdraw. It looks so dangerous that now again distending the bag and going in from the side port thing, hoping that but I should again have done a bimanual technique here. I should have put with the right hand. I should have had a plain manipulator or something to guide the CTR into the eyelet, into the bag there, but it was not happening. And now finally I decide that maybe if I go from this side port, I will be successful. I'm doing the correct thing now, guiding it with another instrument into the bag and pushing it. Let's see what happens. Does it help? Let's see if it helps. Yeah. Okay, so now it seems to be a little better. So the direction of your CTR implantation is critical. You have to use it in such a way that the dehiscence does not increase. Now you can see I'm going to do it bimanually. I go in with the dialer and then I could release it, but my left instrument was ready. And if I needed to disengage it from the dialer, I would have done that. And now put a capsular hook because I want to remove all the rest of the cortex, putting in the lens here. And so thankfully, it looked good. Now see, to add to the troubles, the lens did not open fully in the bag as I would have liked it to. Here I would have loved the Hoya Nanex injector, which would have put the lens straight into the bag. But now my haptic is there. So, it always adds to the troubles. And now I'm just going to gradually, pull it in and bimanually make sure that it's a bag which is not very stable either. But I managed to do it bimanually and I get it in place. Now, what Anurag was saying is absolutely right. In the long term, I have not put in a CTS. I have not supported the bag. But in the long term, it would have been great to support it from that area because it was a big dehiscence. And however, because I have a CTR inside, if in future I do need to do something about it, I'll have to just, pass a suture around the CTR and finish it off. So this was it. And stop sharing it.
Yeah, but first of all, congratulations for showing this. You need the courage. We all goof up, but we always try to cover up. And I really appreciate you showing it in front of the audience.
No, I had to look for something where I could, make me look like a fool a little bit, and then at least
that's fine. We all do that. We are equally foolish,
Yeah.
But first, my appreciation for you to show this case genuinely. On a retrospect, you only tell me what is it that you should have done.
So there were many things which were not correct. See, everything was great till I did a brown cataract with the femto and, made sure that I did the surgery well. I was having that mucus set coming again and again. I think that contributed a little bit. So if your visual field is not clear, take that extra moment, come out. I washed it a couple of times. I asked my assistant to wash it as well. I should have just taken a small bud or something and, kind of got rid of it. See, it was probably impeding my view and that may have contributed to what happened because my visualization was not great. So first thing which went wrong was that. Second thing, sometimes in these bags which are so lax, it's a good idea to ensure that your, the aspiration, especially in femto-assisted surgery, because the cortex is cleaved all along the rhexis. So, it does increase the chance of catching the bag because when you go and, at the edge of the rhexis trying to hold the cortex, you can hold the bag as well. So you have to be slow. You can't be very fast in your surgery. Here it was fast forward. It looks fast, but I was not really as fast as it made out to be. And then, of course, the next one was where, I did happen to create the zonular dehiscence. I should have immediately done reflux, which I did. But I should not have come out with my infusion. My infusion should have remained there. And then from the side port, just like a posterior polar cataract, where we are so careful about not letting the chamber, shallow at that point because you can actually have the PC separate out into a big blowout kind of a thing. I should have just let my infusion on, gone in from the side port with a finer viscoelastic cannula. It never hurts to keep your infusion on and wait. Even if you have to wait for 2 minutes, it's fine. Your assistant can get whatever you need is ready. Then come in from the other side port, put in viscoelastic and inflate the bag completely. That would have ensured that this dehiscence would not have increased from that small 1 or 2 clock hours which was there initially, and the whole surgery would have been straightforward. And my CTR would have gone in so much more smoothly, because if the dehiscence was just 1 or 2 clock hours, I think that would have happened more smoothly. Now, as far as the CTR insertion goes, the most important thing was that we should have thought and decided that this is the direction and this is the port from which I want to put in the CTR. If you have an injector, great. If you don't, just put in a CTR carefully in a way that you don't increase the dehiscence, so away from the direction of where the maximum dehiscence is. I think these are the few things. And then last thing, probably fixate it. If I was mentally prepared, I would have fixated it with a CTS, as Anurag said. Even if you have put in a CTR, you can still put in a CTS and still fixate it. But I felt that my IOL was sitting nicely, well centered. The bag looked good. It was not dipping back. It was like not falling back. So I decided to stay with it. These are a few things that I thought.
Thanks. Very, very well done, very well shown, very well analyzed with an autopsy. And that's why we want an autopsy from you only. Dr. Lahane sir, Dr. Keiki Mehta sir, would you like to say a few?
Well, the only thing I'd like to add is I normally use, what should I call it, a reusable injector, one made by Groider. And it has the advantage that it doesn't kink and doesn't break. So it enables you to inject it. And it was a 180 degree at the end, almost a 180 degree dehiscence. So, I mean, we were fortunate that we got away without a problem. And equally fortunate that he used a lens which had supports at the side. Had he had a loop lens, the loop lens might have slipped up. In many ways, I think Gaurav, we've done a great job. But, I mean, we all get stuck in this.
It came out good, so it looks like a good job. I could have been in the other end, like with no IOL in place or something, or a glued IOL or something in place.
It's just a thin line of demarcation how you could escape, as you said very rightly, Gaurav. You never know, any time it could just slip any which way. It is just good luck that everything went through, the CTR went through well, and it stayed there without moving. Now, one more question, in a place like this, in the end, and if you feel that it's slipping, would you like to also tell the audience that you would like to thread the eyelet of the CTR on the other side in case you got to remove it in that hurry?
In fact, you're absolutely right. I had described this almost 10 years back as a suture secured CTR, where, I just pass a loop of 10-0, and I'm sure a lot of people have been doing it. So I don't want to take credit for it. But, if you are suspicious that I would have only done it, Dr. Himanshu, if I had a broken PC or a broken rhexis or a situation where there was a possibility of the CTR getting lost into the vitreous cavity. Then it's a blessing to have a suture pass through the eyelid, because then you can just retrieve it. So when I'm suspicious of a broken rhexis or I'm putting a CTR in an early kind of a part of the case where I'm not sure that I'll reach the end of the case with an intact PC or with an intact rhexis, then I would definitely pass a suture through it. Definitely.
Thank you. Dr. Lahane sir, anything that you would like to say?
Yes, I think, Gaurav, you have managed very well. You have got a courage. When the CTR is not going on this side, that side. After that also, you thought it will go on that other side, and you manage with that. Otherwise, what happens in a situation like that, you remove the cannula without forming the anterior chamber like that, the capsule also comes to you. So I think it was a very good management, and we must learn from this type of thing that you should be properly bold enough. One small mistake where the visco was not injected, a small mistake has now given so much of the pressure. Do we manage everything? I think the courageous and technical surgeon like Gaurav can manage. Otherwise, it is very difficult to have such type of CTR and then implant. Otherwise, the capsule might have came out, and then the iris claw is very easy. We put iris claw that on the you can say the glued IOL or like that. But really very good managed, Gaurav. I'm really excellently managed case. Thank you.
Thank you so much, sir. Thank you.
Thank you.
So the reason why there is a PC bulge in such cases is that the posterior group of zonules are selectively weaker, actually. That's the reason why the PC bulges the moment you take out the instruments from the AC. So in such situations, I would actually not use low fluidics irrigation aspiration. In fact, I'll go higher up on the IOP so that the bag remains inflated all the time. And I would not put in a CTR early in this case, because when the posterior zonules are lax and you are stretching the equator with a CTR, the space between the anterior and the posterior capsules actually come down. So it tends to get flattened the back. So you hardly have any space to go out and clear the cortex and even put in the IOL. So inserting an early CTR in such cases is not a good idea. You can put it after everything is over, but not before that. And in fact, CTR implantation in such cases is usually not required if you have not produced any dehiscence, as this case had. Because even if the posterior zonules are lax, the equator is quite steady and the anterior zonules are quite okay. So the bag remains steady right throughout. There's no need to put in a CTR if there's no other eventuality.
The only reason why you might still want to put a CTR, I mean, all valid points that you said, Anurag, and very nicely described, but I probably think that I would still put a CTR. These are the bags which are also more prone to get capsular phimosis, and these are the bags which will eventually, so I sometimes put in a CTR if I feel that these bags are going to go into capsular phimosis syndrome, and they often do, and then it can completely deform the lens. Even these hydrophobic acrylic lenses, I've seen the haptics come in front of the IOL, and then you have to do an early YAG release for the, for the rhexis margin and break the phimosis. All the same, all the points that you said is absolutely correct.
Thank you, Gaurav, for an excellent presentation. We are not going to leave you. You have also a series. We are missing out on 2 other cases, but in the interest of time, we have to move on. We would want you back again for some great discussions, and thank you for sharing and being bold to share what you did. Over to Anurag. Anurag is again a very prolific surgeon, a very detailed analysis, and he has a logic behind every step that he's doing, and he's a good teacher. Very precise, few with his words, great surgeon, and it's always wonderful to interact with Anurag. Over to you, Anurag. Thanks for being here with this show at this time.
Thank you so much, Himanshu sir. Profusely abundant thanks to BOA for the platform. Good evening, ladies and gentlemen. Greetings and regards from the land of Jagannath. So I'll just speak about an incident which was an unheralded inclemency that occurred to me one time in the operation theatre. So we see some of the white cataracts peeping at us from the other end of the street lamp at times. And one of those examples is a case like this, wherein the white cataract actually has a different consistency to itself. If you do an ASOCT in such cases, you would see that there are fluid-filled pockets in the mid-peripheral portion. It is not liquefied cortex. Nothing comes out when you puncture the capsule. You cannot aspirate these jelly-like cortex divided by septae with a 26-gauge needle. You cannot do a puncturexis in such cases. So what is left for you to do in a case like this, where there is a lot of mid-peripheral intermescence in terms of liquid gelatinous cortex divided by septae, is the following technique, what works best in my hands at least. To load the anterior chamber with viscoelastics time and again, do a small rhexis initially, do a small bit of hydro at multiple points, and then mechanically rotate the nucleus, which is the best way to break this septae and release this gelatinous cortical matter. Once that is released and the intermescence gets relieved from the capsular bag, you don't seem to have the same bulge in the mid-periphery that you used to have. Then you can snip the rhexis margin at one point, create a microflap, a peripheral girdle of capsule. Then with the help of this is a Haldipurkar pair of forceps. You can use the pair of forceps of your liking. But in the opposite side, it can be rotated. You can use the many ports that are there on the cornea with a microrhexis and normal forceps combined. You can increase the size of the rhexis. So this is what is known as the double rhexis, and we have all implemented this technique time and again in our practice. Let's come to my case then. It was a 78-year-old male. The other eye was pseudophakic already, but was amblyopic, so the visual outcome was suboptimal. The dominant eye, due to sheer negligence, and the only thing that the patient blamed for the condition in the other eye is the surgeon and the surgery. So the dominant eye was not presented to an ophthalmologist till it attained the undesirable intermescence. So this is how the case looked like on table, and I was pretty confident that it would go the same way that many of such cases have gone before. So inflating the anterior chamber with viscoelastic, putting in a nick, a small amount of liquefied cortex comes out, but in the periphery, we can see the wedge-shaped liquid-filled bags already. I wash out that cortex just to have better visibility of the flap. Load the anterior chamber again with dispersive viscoelastic. Take my favorite pair of forceps and rotate it all around to complete the initial small rexus. I already noticed that the capsule is not as deeply stained as I would have liked it to. So I release the flap here. I'm trying to catch it again from the other side. I do get to see the cut flap, the cut end, though it is not as clearly as visible as was in the other case that I showed moments back. So the same technique to follow, micro hydrodissection at a few quadrants, and then mechanically rotate the nucleus inside the bag to break all the septae and clear the intumescence for the next step to follow, which was the double rexus planning. So after the rotation was complete and the liquefied vitreous, which was extruding from the bag, was cleared out with the help of viscoelastic, the next step was obviously to snip the capsular rexus at one point. But after I snip it is where my misfortune struck me. I don't seem to locate where the flap is. I lost the flap. I'm blindly poking at it. I'm trying to grab it from everywhere, but I'm unable to do so despite of repeated attempts. I'm sure that the flap has already extended to the periphery if it hasn't, and it will extend even further at the time of doing the following steps. So the challenges that I had at this point in time was I had a small CCC, which I had constructed initially, and I had no scope of extending it now. So in the bag maneuvers, which we're obviously going to follow, we're going to be traumatizing to the end, which was already open. Even a trivial trauma with the process of a chop can cause further extension if it hasn't extended already. And it was not possible for me. I had no chance of seeing the flap motility sign because I was not being able to locate where it has extended. So the flap motility sign was not available to me. A change in the angle of attack also was not possible because if I was moving superiorly, I was facing the cut end directly, and moving inferiorly was not possible because that would be ergonomically more difficult for the subsequent steps to follow. So the strategy that I had in mind at that stage was the maneuvers were going to be gentle while I was handling the nucleus inside the bag. The phaco had to be slow motion and the fluidics had to be low. Luckily, I use very low fluidics for my routine surgery, so that helped in this particular case. The first half of the chop, I would use to make smaller fragments of the nucleus so that they can be dislodged from the bag for the emulsification. So the fragments have to be small because the opening was small. And the later half, I would try to eat away the larger pieces of the nucleus, not dividing them any further, just to minimize the stress on the capsular bag. I had mother luck on my side to an extent in two things at least. The nucleus sclerosis wasn't very hard, it was not a very hard cataract. And the weakest point of the CCC at least was not facing the line of the entry of the phaco needle, like that happens in a typical Argentinian flag sign quite commonly. So let's see how I proceeded. After this, I took the phaco needle. I knew that it was somewhere there on my left-hand side. So I buried the needle. The IOP stays at 20. The aspiration rate is at 23 or 24. This is my routine setting for any cataract surgery. I always perform my surgeries under an IOP of 20. So I'm just nipping the peripheral part of the nucleus just to ensure that the posterior plate is weakened. I'm not trying to break it through and through. Micro chops, which might not extend to the center. They will extend to the center eventually, but not right now. I'm just trying to weaken the posterior plate so that when I go to the opposite end and divide the initial initial chop that I had made, I would be able to achieve a complete crack. Now I have achieved a complete crack. Every time my chopper is going in, if you can notice, I'm going flush with the nucleus. I'm rubbing against the nucleus and pushing the CCC margin so that I don't engage the small CCC margin in my chopper, at least to create further issues for myself. I still cannot see the flap motility sign. I don't know where it has extended, into what extent it has extended. I have my eyes fixed on that point though. Slowly but surely, I have started to emulsify them. This part is particularly unedited, and now as the time has come when I'm not trying to chop them any further, I'm trying to engulf the whole nucleus, which has not been chopped properly. I can see my first signs of the flap, and to my great relief, I can see the flap fluttering there. So this just ensures that it has not gone beyond the equator at this stage. So this large segment of the nucleus was consumed in the end. The IA follows. Now I'm more confident because I can see that the posterior capsule is intact. So I strip off cortices from one sector to the other. I prefer to use a coaxial IA, barring a few occasions. I would have used a bimanual in this case if I would have not been sure of the capsular status, but now I am. I cannot see any crack, and the brilliant red glow offered by my microscope is also aiding in the process. So I strip off cortices from one sector to the other. There have been a few catches of the PC in the process, but I've released them with no difficulty at all. And this is happening basically because I'm stationing myself more centrally than peripherally. Some of the stubborn cortical fibers are remaining, which I flush out using viscoelastic all around. Now I know that I have a keyhole kind of a capsulorhexis, but the capsular support is enough for me to implant a single piece IOL as was planned initially. However, even with the best of materials that is available in the industry today, such a small capsulorhexis should not be left behind because I have enough to spare. So the trailing haptic just needs to be tucked in. I avoid rotating the nucleus, rotating the IOL too much in the bag. This just is tucked in, and I leave the elasticity of the haptic to cause an expansion and occupy space in the equator. Now the small rhexis has to be expanded. So now I snip it. I can see the capsule thoroughly. This step is done under the cover of BSS. I hate using viscoelastic towards the fag end of the surgery. In fact, I hardly use it beyond this step of capsulorhexis. You just need to change hands so that ergonomically every part of the capsule is more accessible. Under cover of BSS with an IOP of 55, it's but natural that the capsule will flutter a little bit, but that's nothing if you grab it properly and just rotate it all throughout to produce a rhexis of a desired size, and the IOL can also remain stable for years to come in the eye. So the places where I went wrong and I would like to resurrect would be, I understand that I had not stained the capsule properly. I should have probably stayed with the stain inside the anterior chamber before flushing it out with viscoelastic too soon, so that it would have taken more stain. I was clearly overconfident there. And even after I lost the flap, at that stage, it might not have extended to where it had extended, where it had ended up extending. I probably would have stayed a little longer and done some capsular painting locally. Even if it was filled with viscoelastic, I could have done a local wash of the BSS, of the visco with the BSS, going through side port and paint the capsular, the local area of the capsule, just to ensure that the capsular flap is something I can see. Perhaps there I could have fashioned another flap, just like I did in the fag end, and probably would have salvaged the capsule, would have, in fact, done a better job in extending the capsule to a desirable size, which probably would have done my job a little easier in the end. So thank you so much. That's all I had to present in this segment. Thank you for the opportunity, Himanshu, and stop share and take questions if there are any. Thank you.
Yeah. Thank you, Anurag. I think great presentation, great survival. Just for the benefit of the general crowd, the flap motility sign that Dr. Anurag was talking about was devised by Dr. Rohit Om Prakash, wherein what he says is very simple, that if you have a tear of the anterior capsule going beyond till the equator, you're not sure whether it's beyond the equator or not, and whether the posterior capsule is stone or not. If you see that the two edges of the flap are floating and if the flap is mobile, you know that it has not gone behind to the posterior capsule. From your third eye, as you are doing your fluidics and you are doing your phacoemulsification, it's always nice to keep an eye on the flap motility so that you know where you have crashed and where you're not, and you can still go on. And that's how Anurag came out so well. Though despite poor visibility and he could not even see the flaps, he came out with flying colors. Excellent surgery. Anurag, brilliant. I had a great time watching it. Gaurav, would you like to say anything with Anurag?
Anurag, it was so well managed. I was so happy to see how you actually managed it. And it came out so beautifully and then meticulously, enlarged the rexus again, in spite of that being a broken rexus, but you did the right thing because you didn't need that redundant capsule over there. And the IOL placement was done so well because you manipulated it into the back so gently and nicely and, left it there just at the right place. So I think you've already covered almost everything. What I do think is that when you see, I used to stain my capsule exactly the same way as you just did there. And often then the stain doesn't come out so well. But, frankly, even though I've been staining for like 20 years when Trypan Blue first came out, maybe 20, 25 years back. But, I used to previously put in a bubble and then stain it. Then I stopped doing it just like you did. I didn't put the bubble because I thought it slowed me down and, it's okay to just push in some Trypan Blue and get the stain and then you have to just wait for a little longer. But what I've learned over the last few years, in fact, you never stop learning, is that if you do put in a bubble, it occupies sufficient space and then you can just, with maybe just 1/10 the amount of dye which you used, you can just get a uniform stain and you don't need to sit there for very long. You just need to put in there for about 1 or 2 seconds and then you just wash it out. The stain comes out beautifully, uniformly, with much less dye than you would otherwise use. And I have seen some other people do it very elegantly under viscoelastic as well, which I don't enjoy doing because sometimes it just makes the viscoelastic, full of dye and, you have all that material which is, viscoelastic stained with Trypan Blue and then you have to wash it out. So I think I would have only done that one bit differently. And maybe even if I had gone on with the surgery, then as you said, I would have stained it again before trying to attempt an enlargement of the rexus. These are the only two things. Otherwise, you did everything perfectly. And that's all I would say.
Yeah, so the staining in a white cataract, even we remember, Gaurav, we had a time when there was no stain. Trypan Blue came later. And we used to put a side port just to have a illumination from the side so that we could have, you are blind in the rexus with the fluid coming out and the white rexus. I mean, a lot of young people cannot imagine a stage. It's like without internet, we have had our life without internet. And it's like without Trypan Blue staining of the anterior capsule and yet doing a capsulotomy was a very tough job. But I think staining. And one more thing that I've learned is keeping it for a little longer time, no harm. It really helps because at times these capsules are tough, they don't stain well. And when you want it to be stained in particular area where you could go away is the one which is not stained. It stains not uniformly. On a regular cataract, it stains uniformly. In a white cataract, it doesn't stain uniformly. So that is one thing. We would talk next time, with just lack of time, that how would you approach a white cataract? An intumescent white cataract which is highly pregnant, and the Argentinian flag sign is the easiest thing to get. You just touch it and it blows. So how well to avoid it, whether to nick it, aspirate it from the side, from the center, whether a small rexus, a puncho rexus, I think we'll discuss that some other time. But at this point, your surgery was great. Harshul, you would like to share something?
Yeah. As usual, Anurag, he is a wonderful surgeon, Anurag, prolific surgeon. 2-3 points I'd like to put here, Anurag, that what is the size of your initial rexus? I guess it was 4 millimeter?
Yeah, around, yeah.
Less than
that. So if I had the same situation and with this brittle cataract, and I know that visibility is poor, I wouldn't have attempted to enlarge initially, Maybe through 4 millimeter, you can take off this white brittle cataract. That's the first thing. Of course, you also said that, yes, staining was not that well. Other thing is, even when you finish cortical matter irrigation aspiration, then also I think at no stage we should come out and let anterior chamber collapse. You are doing, because at that stage also we can have a wraparound tear from, so we have to maintain anterior chamber till the end. So that's the only 2-3 points which I wanted to add.
So
apart from the
I
fact
have,
that the way I love to do, as Dr. Himanshu said, we'll discuss some other day. I make a very small rexis in center. I make just 2 millimeters. There's the smallest rexis I think which may be possible. Through that, I'll love to debulk the capsular bag or whatever. But we'll discuss it in some
Let's
other
finish it.
episodes.
Let's finish it now. Now that we started, you touched the point. Let's do it now only. There's no better time than now. Now the maximum stress on the capsule is in the center. One more thing that I learned is go mid-periphery to aspirate a little more. And so sometimes, right, you give a nick and it just goes and spreads everywhere because the fluid starts coming in. And whatever you do, still 30% of the time, please remember, friends, you can land into trouble. Whatever you do.
But it's important that we go and debulk from both the side ports, from main ports, so that you try to debulk almost 270 degrees of the capsular bag. And I use Dr. Gaurav, my theme, viscoelastic cannula. It's because it's curved like this, so it's very easy to insert. On from one side port you go to one side, other side straight, so it reaches in a wider area. I use the same thin cannula to aspirate, and then I enlarge the rexis to the proper size. Yes, Anurag?
One of the things that I've observed of late, I cannot really explain why this phenomenon happens, but I have observed it of late, is that in such white cataracts, after we put in the stain, if we push in some amount of chondroitin, and below that, if we push in the HPMC, I don't normally use, in fact, I would recommend the use of hyaluronate in such cases, because it creates a weight and it largely is centered around the center of the capsule. It does not uniformly spread and flatten out the capsule all throughout. So when I use the chondroitin, a small quantity of chondroitin, initially it appears that the chondroitin has actually taken up the stain and it looks blue all around. But then underneath that, when you push some amount of HPMC, the whole stain vanishes. And that way, somehow, the capsule takes up stain all the more better. I don't know why it happens, and I can't explain why it happens, but this is something I've just observed over a period of time. And then the initial size of the rexis, which is around 3.5 to 4 millimeters, I have tried taking out, and you're right, Harsh, a lot of times we would be successful in taking them out through such a small rexis. But what happens is, you must remember, there are flecks of cortical matter constantly coming in and murking your view while you're chopping. So the heat of the moment, when you are concentrating on your chop, there is every possibility that your chop might just engage one area of the capsule and produce a dented tear there. So it's probably a better idea, whenever you can, just extend the rexis to sufficient proportions before you proceed. Probably would be a better idea, and you would be safer that way than to carry it on through a smaller rexis. But what you're saying is right. I mean, if you can pull it off through a smaller rexis, nothing like doing it away first and then extending it in the end after you put in the IOL.
Thank you. Dr. Lahane sir, anything that you would like to comment on? Manish, would you like to say a few words somewhere? Dr. Lahane sir?
I think Anurag has did it very well. And what the flap, he has only told what he should have done. And I think that time the staining was important. Secondly, why it was not stained? Because in intumescent cataract, where there are the water vacuoles are there, on that area the capsule never gets stained. So because of the elevation, it stains around. And so you should keep it slightly, you can say 13 to 17, 20 seconds. And that will stain, or also you can use the air bubble. But when there was a capsule broken, that time again the staining would have been helped more, and you can remove ISCO that from that part and you can stain it, and then you can do the rexis. Doing the phaco in such situations, sometimes, see, Anurag is a prolific surgeon, but sometimes that may tear to the periphery, and that may tour to the posterior capsule. So it is to better to just extend the rexis and then go ahead. But yes, as he has not given any stress or you can pressure on that side, did Fuku away from that area, and that is a very good thing. That whenever you are doing, don't give pressure to that area, that bag. Do it on the other side, and then he managed with the rexis. I think Anurag, you managed very well. Thank you.
Thank you.
Thank you, everybody, for being with us till the end and making the most out of this situation, and with your time, with all the experience and all the time that we have had. I think a great learning session from everyone and a great participation wholeheartedly. There is so much to learn always, despite saying that it is only a cataract surgery. I think there is so much to learn at every given point of time. I sincerely thank all the participants for their valuable time and input that we have had. It's a great. Over to you, Manish. Would you like to say a few words?
Thank you so much, sir, for coordinating the show, and a big thank you to all the speakers, to Dr. Harshul, Dr. Namrata, Dr. Gaurav, and Dr. Anurag for their pearls of wisdom, and a big thank you to Lahane sir and Dr. Keiki Mehta for their inputs. I would like to apologize for the inconvenience because of the YouTube problem. It was not really at our end. It's a problem that has happened to YouTube India. We hope to have a bigger audience the next time round, and I'm sure that our minds have been adequately stimulated, and we will be eagerly awaiting the next edition of iCrash, which we will announce well in advance. So thank you so much once again, everybody, and have a good night. And Himanshu sir, your closing words.
But what I want from the audience, whoever has attended, please give us a genuine feedback. What is it that you liked? What is it that you'd like us to improvise? What was the learning like? What is it that you really want? Was this helpful or not in day to day? And that would be a great point for us to move on to the next session. And Manish is coming out with something very interesting during the monsoon picnic very soon, in next 24 to 48 hours. All our participants are welcome to come for the monsoon romantic picnic that he's arranging in near around Bombay. And Bombay in monsoon is absolutely gorgeous. So be ready for the next announcement that Manish is coming out with.